Welcome again. Hi everyone. We are back with another session with Hirad P. And today we're going to continue to review the latest Afib guidelines that published in 2023. This is part A. And today we're going to review the guideline recommendation and information regarding anticoagulation before and after atrial fibrillation, catheter ablation. Also, we're going to talk about a little bit, one slide about complications of catheter ablations. And after that, we're done. All right, so let's start and then start with the first important part. Let's get to it. Okay, so let's talk about anticoagulation during and post. Before ablation, of course, we would like to have 3 to 4 months of appropriate anticoagulation. And sometimes when we are not sure about it or something happens, we can do transesophageal echo at the time of ablation to rule out any issues with the left atrial appendage thrombus. But if the patient is on Coumadin or warfarin, we would like to be on it without interruption. So uninterrupted warfarin is the best approach for keeping the patient well anticoagulated during procedure and after the procedure. And the INR target is usually about 2 to 3. So there's trials, as you see here. Let me get my marker. There's a trial called Compare trial that actually answered this question and compare the interruption versus uninterruption of warfarin. And they found if you don't interrupt, you continue with your anticoagulation before, during, and after the procedure. Of course, you get some heparin, intravenous intra-procedure heparin during ablation. But if you continue without interruption, you will have less issues with the bleeding as well as stroke, of course. So it's efficacious and safer than if you interrupt it and restart. Also, in case of DOAC, they found if you do minimal interruption or continuously anticoagulation during procedure of ablation and continue afterwards also, these are beneficial comparing to interruption of DOACs. So DOACs are direct oral anticoagulation, including Eliquis, Xarelto, or rivaroxaban, and the rest of the family. Now, they also had some trials and study that shows minimally interrupted. So if you interrupt it minimally versus you do it uninterrupted and continuously, there was not much differences. Now, in my cases, I usually hold the morning dose of Eliquis or the day before Xarelto or rivaroxaban. And the reason is I'm a little bit worried about during procedure if there's something happens and I wanted to reverse the anticoagulation. But that's it. So I don't stop anticoagulation more than 1 dose before the catheter ablation. And so this was during and before. So during for the Coumadin will be uninterrupted. For DOACs, minimally interrupted, maybe 1 dose stopped before the procedure. But what we do after the procedure. So after the procedure, there are a lot of data that there is an increased risk of stroke because of the catheter manipulation inside the left atrium, because you can cause inflammation and there is irritation of the tissue. So there is increased risk of stroke, especially for the first 30 days and especially for the first 7 days. Post-catheter ablation, there's an increased chance of stroke up to 0.8%. So there is a significant number of patients that can get stroke, although nominally is like around 1%, but it's still significant. So that's the reason it's very strongly recommended that you take blood thinner without interruption, no matter what it is, Coumadin or DOACs, at least 2 months, minimum of 2 months, and the best is to have a 3 months post-procedure. Now, after 3 months of the procedure, so you've done a great job, the patient got ablated, the decision about after the 3 months is not clear yet. So there are some trials that looking at that choice of treatment. And the question is, should we stop the anticoagulation if we are very happy with our ablation, or just continue with the blood thinner no matter what based on the CHA2DS2-VASc score. If it's more or equal to 2, the patient needs to be on anticoagulation. And in the same line, there was this trial that just published, option trial, looking at the combining appendage closure with ablation, showing non-inferior to the blood thinner after the ablation as well. So this is also another option. So the option number 1 is if you have a paroxysmal atrial fibrillation, for example, and you did a great job after 3 months, are we safe to stop the blood thinner? There are some study that shows the risk of stroke goes back to normal, and there are some studies that shows there's no change, but the randomized trials are ongoing, and we will have a better answer soon. Some of these trials are linked for loop recorder implantation, some of them using Apple Watch for screening the patient for atrial fibrillation. So soon we will get a better understanding of what to do after successful catheter ablation. 3 months after 2 to 3 months of anticoagulation, what should we do next? So we'll see, as hopefully soon we get one of these trials out and we have a better understanding of what should we do. So first I want to correct something about the previous slide that I mentioned about 3 to 4 weeks. So what is the correct one is to have a 3 to 4 weeks of anticoagulation prior to ablation, and 3 months post. 3 to 4 weeks before, and 3 months post. I mentioned month for the pre, so please apologize for that, and the correction is right here. Now, let's focus on complication after atrial fibrillation ablation. So there are different ways of ablation of atrial fibrillation. And we used to had a lot of different modalities, ultrasound, laser, but the two major modalities were freezing, called cryoablation, and then was radiofrequency, which basically using burning techniques. Now recently we have pulse field ablation as well, which there are some complications that we still see with the pulse field ablation, and some that we don't see as often or rarely we see. So this complication after Afib ablation is basically based on the data that we have from freezing as well as burning radiofrequency ablation. So complications are, the serious complications less than 1%, but it can go up to 5% if we include the issues of getting to the vein in the groin, like vascular access complication, which that increases, which usually are more benign or easy to manage. And then there are some evidence that if centers do less than 25, the operator do less than 25 patients per year, or the whole facility does less than 50 patients per year, there's an increase in complication rate. The second thing, there was some data that shows patients, especially ladies, have a higher incidence of complication, but in recent trial, a combined trial showed that this is not true. And overall, we're getting better with procedures and all across, so we have a better tools to decrease the chance of complications, closure of the groin, that will decrease the bleeding in the groin. But setting aside, if we go over to the table right here that basically summarize most important complications here, we have one of the most important and fatal one, fistula, a connection between left atrium and esophagus. This is a very rare complication. It happens in 2 in 1,000 patients, so 0.2%. And timing of the complication usually happens within few weeks post-procedure. They present with issues of esophagus and sometimes chest pain and fever. The first thing that can identify the problem is CAT scan of the chest, and of course you need to have high suspicion, because sometimes CAT scan also can miss the diagnosis. And the most important thing is to do the surgery as soon as possible. The second thing is a cardiac perforation with tamponade, which basically means blood goes around the heart and put the pressure on the heart and drop the pressure. This cardiac tamponade and perforation also happens in like 0.4% to 1.5%. It happens during procedure because we have a lot of indwelling catheters, we're doing transseptal punctures, and at the same time the patient's on blood thinners. So all of these together increase the chance of the bleeding around the heart. And it shows itself with the hypertension, and you need to have high suspicion. We usually use ultrasound of the heart. We have ultrasound also inside the heart that help us to monitor this quickly and prevent and treat it quickly, which is basically draining the blood around the heart and reverse the blood thinner. And sometimes in rare occasions you need to take the patient to operating room, and if there is any kind of area that needs to be fixed and sutured by surgeons, that and also take care of the issue. The other issue that we talk about area is having stroke or transient ischemic attack. That happens also in 0.8% of the patients. Usually happens either during procedure or up to 1 week post-procedure. So as we discussed, the 1 week or post-procedure, it has a higher chance of a stroke because you're getting very hypercoagulable. Means you are more prone to get clotted. And that's because of inflammation, because of a lot of things that we just mentioned. And they presented with stroke signs. Also during procedure, we have like bubbles, we have clots that can go up as well. And MRI and CAT scan will help. And also there are techniques that you can treat them. And the other one is a pulmonary vein stenosis, means the veins that we ablate is get strictured and then get tight, and then that cause symptoms. Usually you need more than 1 out of 4 veins to cause trouble, and usually happens within few months. Sometimes presents itself with the hemoptysis or bleeding, bloody sputum, and that's because of increasing pressure in the alveoli. MRI and CAT scan also and other imaging modality can show the stenosis. We see it less recently because the ablations are away from inside the vein these days, and it goes to the antral, which is a kind of mouth instead of inside the vein. And also with the new modality, pulse field ablation, pulmonary vein stenosis was not reported and was rarely reported. So basically we have extra safety. Then is the phrenic nerve paralysis, especially if you're ablating the right side veins. The phrenic nerve in some patients can be very close. This also is rare, seen in 0.2 to 0.4%. And usually I mark the phrenic nerve and I avoid it. And if your phrenic nerve is marked, basically this will be almost zero to damage the phrenic nerve. And we get to the vascular access complications, during procedure, if there's damage to the vessels, including artery, or there's a connection between artery and vein, sometimes you need to treat those as well. Rarely we see death, most likely during procedure, maybe from the perforation of the heart. And a few days after, you also can get pneumonia, especially we do intubation, and then some risk of aspiration pneumonia is there, so the patient present with cough and fever, and the chest X-ray will show the problem. So this was basically the complication that we see. As I said, pulse field ablation might change the complication frequency as well as the type of complication. I see inflammation of the pericardium, pericarditis with pulse field ablation, maybe slightly more than other modalities, but overall we see more safety and less complication with the pulse field ablation. So with this note, we'll finish this week, and hopefully next week we see each other, and then we talk about another interesting aspect of atrial fibrillation management from the guideline. Also soon we're going to add another section, and I'm going to introduce one of the interesting papers that I came across that I think will be helpful for you guys to review. Again, thank you again for all your support. Please, if you find this helpful, subscribe and like and tell your friends. Have a wonderful week. Bye-bye.